speaking. So today's session will be a very interesting session about the neurocritical care prognostication of post-cardiac arrest survivors. And with us, a lot of eminent speakers and the panelists also. So first, I would like to introduce Dr. Tapas. Dr. Tapas is going to talk about prognostication after the post-cardiac arrest in the today's session, and he is one of the leading critical care specialists in Jharkhand, Ranchi Medanta Hospital, and he has done his DNB, FNB from Gangaram Hospital and fellowship from the Toronto General Hospital, and he has a special interest in neurocritical care unit. So we definitely glad to have him here. And with us, our other panelist, Dr. Kapil Jitpe sir. I think no need for any introduction. Sir is one of the dynamic speaker and one of the dynamic members. He was the past president, and a lot of position he has held. Actually, it will be I think it will take me a lot of time to speak about his credibility, but only the few salient points, like he is one of the president Association of SAR Critical Care Societies, past president of ISCCM, and vice president also before that. And he has also a lot of book publications, and particularly his area of interest is neurocritical care unit, and he is presently heading the critical care unit neurotrauma center Ruby Hall Clinic. And with us also, welcome sir, Dr. Jitpe sir.
Namaste. Okay. Thank you, Guru.
Yeah, and with us, Dr. Harsh Sapra sir. He is basically heading the neurocritical care and trauma unit at Medanta Hospital, Gurgaon, Delhi. And his particular area of interest is neurocritical care management. And let's hear some few words and few messages, take-home messages from him today. Welcome, sir. Harsh sir.
Thank you, sir.
Yeah. And with us, our one of our other panelists from outside India, from Bangladesh, Dr. Ujjwal Kumar Malik. So he is the secretary and the member of Critical Care Society of Bangladesh. Basically, he is very much interested in academic, and and he's happy to remain with us, associated for a long term for this academic event. So I welcome Dr. Ujjwal.
Thank you, sir. Thank you all. I know about Kapil Jitpe sir. I meet him in Kochi on a neurocritical care workshop, and personally meet with him. Probably he can understand me. And also meet in Melbourne, World Federation of Critical Care. Sir, namaskar, sir.
Yeah, namaste, Malish. I definitely remember you. Ujjwal.
Thank you, sir. Thank you, sir.
Yeah.
So with this, my co-moderator, Dr. Akhilesh, intensivist at Apollo Hospital, and myself, Dr. Gunadhar Padhi. I'm the coordinator and consultant, senior consultant, Apollo Hospital, Navi Mumbai. We also had a almost 20-bedded neurocritical care unit. And so with all this background, I think I invite Dr. Tapas to present the today's talk on prognostication after the post-cardiac arrest. So Tapas, can you please start?
Yeah. So good evening, Jitpe sir. Good evening, Harsh sir. Good evening, Dr. Ujjwal, and two dynamic duos from Apollo, Navi Mumbai, Dr. Gunadhar and Dr. Akhilesh. It's a pleasure and privilege to be here among the stalwarts in neurocritical care. And I will first thank Dr. Gunadhar and Dr. Akhilesh for starting this initiative of conducting every week one of controversial topic for the discussion part for the junior trainees, because they are the only people who need actually guidance, because all the seniors, they have their own experience. Definitely they share their experience, but it's the need of the hour is for the trainees. So definitely a very innovative idea and as well as initiative from the two dynamic intensivists. So today Dr. Gunadhar and Dr. Akhilesh has requested to discuss about something which we all do, but definitely there is so many flaws and the controversial areas or gray areas, we'll say, that we need to discuss and take the consensus from our Indian experts, because all the articles, most of the articles in the last 5 years, we started from ISCCM, Jitpe sir as well as Harsh sir, they have taken the initiative. Now we have our own guidelines as well as the position papers. But before that, it was all related to the European Association of Neurology or American Association of Neurology or AHA guideline, something like that, that put the light on the prognostication after cardiac arrest. So we decided to discuss about, let's learn the art and science, because it's not only the art or only the science, it's combination of both. So with this, we all know that nobody wants cardiac arrest in any of their patients in the hospital. Also, there are certain areas where the patient or the person suffers cardiac arrest. We all know, day before yesterday only, one of our favorite singer, playback singer, has suffered cardiac arrest after doing the concert. And we are all know from our childhood days the songs from KK. So nobody wants that. So the effort as intensivist actually doubles or triples when we get this type of scenarios or patients in our hospital. And also there are certain areas where the patients are being shifted from other hospital after reviving, or the bystander also, they save the patient and shift the patient to our emergency department and ICU. So now the role of intensivist starts from there, if I will say, because patient has been survived by our bystanders or the intensivist efforts. But now the problem is we need to now start the resuscitation part, post cardiac arrest care part, and then we need to again face the family, because the family is right now outside the ICU or outside the emergency department or ICU, the hospital. Now we need to address their concerns, because they are now totally devastated by the untimely cardiac arrest or whatever may be the disease process. And now they want some reply from the intensivist, the neurointensivist who is treating that patient. Now, so in next 30 minutes or so, I would be discussing the in-hospital as well as out-of-hospital cardiac arrest survivors, like how we need to start the prognostication part. Now, there are certain gray areas I have already told that we will also discuss. And I will take example of a real case, because that actually should be done, because it's not the theory part, rather how we do it in the Indian context, Indian perspective, when we do at our bedside. So we have so many these stalwarts here. So definitely we'll take their opinion also at the end, how these type of things happen day to day in our practice, and what are the take-home message for the young trainees and all of us in our the next patient when we'll receive like that. So to start with, we all know this is again resuscitation outcomes consortium. I have taken this picture, and in that they have found almost out of 2,200 the cause of death in the non-survivors after the out of hospital cardiac arrest patients. Largest cause of in-hospital death was WLST. WLST, we all know, that is withdrawal of life-sustaining treatment, and that's for neurologic reasons. Almost 61%. You can see here the tall tower here at the end. And there are other causes. We all know, whenever a patient, cardiac arrest patient, shifted post revival in our ICU, and we anticipate also re-arrest. Sometimes patient is having multi-organ failure, patient is having intractable shock post cardiac arrest because of myocardial stunning, cardiogenic shock. Now also after 1 or 2 days, we realize that this patient is having brain death. And also sometimes the neuro part is okay, but we think of withdrawing the life-sustaining therapy for non-neuro regions. Maybe the end-stage lung disease, maybe the ARDS is severe, something like that. So there are so many causes of withdrawal of life-sustaining therapy. Now, the problem doesn't end here. If we'll think that we should continue, rather the literature, they have shown us, the literature actually puts the light on that if we would continue treating that patient for some more time, maybe the patient awakens. So the literature, they have shown that maybe premature withdrawal of life-sustaining therapy should not be done in all patients like this. So now the other party or the opposition of this argument, they have their own theory, because in India we cannot continue with aggressive care maybe we do not know that it will prove futile. And also in the resource limited settings in India, which is a developing country, so misutilization of scanned resources sometimes can happen. Like if we'll continue to like treat the patient in ICU, post cardiac arrest, no neurologic recovery, but as per the theory or as per the discussion, now if we'll continue for 7 days, maybe there will be financial burden to the patient and patient's family, as well as there will be also the needy patients, the young patients with like where we can reverse the disease process quickly, or maybe with our treatment may not get a bed, or the resources may be misutilized with the manpower or logistics or whatever. So it's a battle between the two the perspectives we need to think about before going for the final verdict. Now, so the background like with which we will start the discussion for today's lecture. We all understand prognostication is difficult. It involves so many, like you can say the art and science, which I have already mentioned, emotions, like the prognostic indicators are not very well validated. And also we do not know that whatever we are right now using the test, that is not 100% specific as well as sensitive to declare that this patient is not going to recover. There is always a inherent risk of falsely pessimistic prediction. So if we'll go for like declaring that okay, this patient is having 30 minutes of CPR time, the patient was having 1 hour or 30 minutes before the patient was unattended, now this patient is not going to improve. So definitely there is a chance that we will go for a falsely pessimistic prediction. Then in the literature or whatever our seniors have told us in our training period, there is a the tag period of 72 hours. We all know 3 days, something like that. So there is an obsession with that 72 hours being the time to prognosticate. That means if the patient is not waking up after 72 days, let's call the family and have a the meeting fix, and we'll go for declaring that yes, this patient is not going to make it. So there are a certain gray areas or the things which still is not clear in our day-to-day practice. And if we'll tell about the quality of our ICU care, definitely this prognostication of these cardiac arrest patients is a core business. We need to understand it very well and also apply it in our day-to-day practice. Now, so that's why I have taken the 2 cerebral hemisphere, one about science and one about arts. So we need to think about very seriously, and I will use so many theories or the research methodology or test in my discussion for the young trainees that will make this understanding a little bit more in a better way for applying at the bedside. So it's not all about only tests I will discuss. Definitely a test or algorithm I will develop at the end. But yes, we need to also think about how we can understand the nitty-gritties, why it is so much of complicated to explain the neuroprognostication. And so many researchers, if you find in the literature, in the Google, in the up-to-date, it will flood with articles. So let's start with the real case, which happened in my ICU, neuro ICU. A 60-year male teacher, hypertension, type 2 diabetes, and ischemic heart disease. He presented with fever and pneumonic patch. He initially was treated in some outside hospital. Now he presented to our emergency department with pneumonia and sepsis. After 4 hours, patient presented to the ICU from the emergency department. Suddenly he became unconscious. CPR started because of cardiac arrest, and the ECG rhythm was VF. So immediately shock was given, and ROSC was achieved after 25 minutes of CPR. So it's a normal routine practice everywhere. It's not very new thing what I am telling, but yes, in the emergency department, the patient was started CPR and then shifted to the MICU, medical ICU. Now, this patient was continued on lung protective ventilation, vasopressor, inotrops, mild hypothermia management as per the literature guideline. Now, if I will tell what is the road ahead for us, like this type of patient, post cardiac arrest, survived and now shifted in your ICU, and you are now maybe in the evening duty or night duty, and what should be the approach. So I will have a flow. This is the presentation, post cardiac arrest survivor. So that can happen. One is immediate. One is day 1 to 2, which is in front of us, like 24 to 48 hours. We'll just keep the patient, like observe, no sedation, no paralytics, just give some time, rest. Now day 2, 3 to 7, which will be like little bit of ample time to say that yes, that patient is not having any neurologic recovery, or we should give the family relatives some clear hint that yes, we are not making any better progress in my patient care. So this can happen. Now, the one spectrum is this patient can awaken right now. One spectrum, the other side, which is not acceptable or we don't want that to happen in my patient, is brain death. Or if the patient is also recovering some neurologic recovery, but yes, that is not up to mark. So that patient will land up in persistent vegetative state, that is PVS. So this can happen either way. And if the patient will continue to in ICU with the ICU management, whatever we are giving, sometimes also the patient needs long-term support. So these are the the things that can happen to my patient if I am getting this type of patient. Now, how do we really prognosticate in this type of patient? Let's go into detail of the statistics and the tests and the reasoning, how we should approach. Let's take the example of Bayesian reasoning. So there is a pre-test. As per the literature, we all know we'll take one test that would help us to prognosticate whether this patient is showing some improvement or not. Yes, as per the pre-test, there would be chance, as per the literature, that 30% if the patient is right now showing the test positive, so survival is 30%. Finally, if you'll continue treatment in our own management, intensive care management, good outcome happens 20%. So 30% in the literature and 20% happens in the real picture, real world. Now, the problem here, let's do a test. In my patient, septic shock, post-cardiac arrest, fever, pneumonia. There will have a post-test analysis, like whatever we do in our exams, in our day-to-day practice also, there is a post-test analysis. So good result happens after putting the patient, subject the patient to the test. 50% patients will survive and 35% will be having good outcome. That is the normal post-test analysis. Now, there is another spectrum that can happen where the bad result will happen. You cannot justify that any test you will apply, the test will be always have a good result. No, 59% is good result, but there is another spectrum bad result. Let's take the example 41%. Now, if we will continue treatment with the whatever the bad result is happening, but we will continue maybe for 2 days, 3 days, 7 days, something like that, 10% of the total patients they survive and 5% will show good outcome. So this is the normal what I will say Bayesian reasoning. Now, ground reality, in a case of post-cardiac arrest, when we are dealing with life or death, or whether we will go for the withdrawal of life-sustaining therapy, or we will say goodbye, so we cannot take any chance. So that is the problem, point number 1, when we will go for neuroprognostication. Now, we want to be realistic. We need to set some reasonable expectation for my patient. We cannot make a mistake here. It's not about putting noradrenaline or dopamine, noradrenaline, adrenaline, so ventilatory APRV mode or the volume or SC control mode. It's not like that. We have to take a decision. So no rebates when we stop life-sustaining therapy. So we need to have or apply a test which will be almost having 0% false positive rate. So FVR has to be 0%. But yes, in reality, there is not a single test which will be having 0% false positive rate. But yes, we need to touch, or we should utilize or think of having some test which would give us at least something near to 0%. Now, whatever in the literature, why the literature is flooded with so many articles, but still it is a controversial topic as per our starting point. Because whatever test they have actually applied and the literature, they have taken the N number, that is the number of patients in their literature. It's almost around 100. So if we'll take 100 patients, so it has to be, the confidence interval would be around 0 to 3%. That means there is always a chance that 3 out of 100 patients, definitely you are actually taking the tube out, but that patient, if you would have continued with the treatment, maybe they would have survived. So you are actually taking the life because you do not apply or you didn't apply a right test to that patient. So that's the problem with the literature, and that's the problem what have shown in most studies. They have the total number of cases is around 50 to 100. So we need to have at least 300 numbers in so that we will reach the confidence interval 0 to 1%. So that's the first point. There is another gray area, that is self-fulfilling prophecy. What do you mean by that? Do a test, there are two possibilities, good result, bad results. So good results, some patients will live. So that means the percentage of patients getting like life or the recovery will be more. That we all understand. Now we'll continue with that. So there will be some patients live. But if you withdraw in some patients, more patients will die, because those patients you have to continue because the patients is showing some good results with the test. Now, there is a terminology likelihood ratio. That means odds of surviving with bad result divided by odds of surviving before the test. So there is always a chance that though the test is showing bad result, but if you continue with the your management, maybe there will be a 2%, 3% chance that these patients will also show some improvement after maybe 7 days, 10 days, or like if you continue for more days also. So the bottom line or message what I want to say, because you use the bad test to decide to withdraw the life support, now the likelihood ratio is artificially small. That means we have induced a likelihood ratio of low because we used a wrong test to decide whether we should go for premature withdrawal of the life sustaining therapy. So that's the point number 2. Now, with that background, there are certain key principles we should follow while we are going for neuroprognostication at the bedside. Early communication with the family, delay prognostication. Don't go for within 24 hours call the family and prognosticate that yes, this patient is bad. No, that's a bad practice, should not be conducted, or should not be when you are in the ICU, you are the attending, you should apply that yes, there should be some delay in the prognostication. Multimodal evaluation, that is the mantra for everybody. Multimodal. Don't use one test and say that this patient is not going to recover. And finally, be patient. Don't be in hurry to conclude something what is actually is not in your control. Now, early communication, everybody knows you have to have good rapport, good relationship with family members. Meaningful information should be given to or shared to the family. And also you involve other physicians, neurologist, maybe other anesthetist, maybe some other team members should be, so that it will be easy for the family member to address their concern. Now, regular interaction and documentation is pivotal in your neurocritical care practice in this type of patients. Delay prognostication, 72 hours if patient has received temperature control. If not, maybe 24-hour first assessment should be there. And then afterwards, you have to further prognosticate after 24 to 48 hours later. There is always a phenomenon of late awakening. I have already told late awakening, maybe 14 days after also there are patients, there are certain category of patients, they have showed improvement. And also they have also full neurologic recovery also. And there is also one subset of patients, doctors, experience of the treating physician comes into action. Now, be patient. You need to understand the pre, peri, and post-arrest factors, what actually led the patient to suffer this cardiac arrest, and you need to continue to deliver timely, optimal care. Now, our patient, if we will discuss about our patient, now this patient is showing pupils reacting 2 mm sluggish, corneal reflex present, eyes deviated upward, no oculocephalic response, triggering ventilator, gag and cough is there, and flexor posturing to pain. Now, BP is 140/60, no vasopressor, ABG, pH is 7.26, PCO2 46, 146 is PO2 on FiO2 0.5. So that's the situation for now. Let's move on. When we discuss about the etiology of cardiac arrest, the prognosis remains extremely bad if the pre-existing condition like metastatic cancer, end-stage heart failure, end-stage lung disease, devastating intracranial or spinal injury. So that means in these situations, you should prognosticate a little bit, I think, in a early fashion to the family relative that yes, the chances of recovery is really, really dismal. So etiology of arrest should be reversible so that you can have some hope. Physiologic reserve has to be there to tolerate this critical illness, and also neurologic prognosis need to be understood, and also you have to examine in a proper algorithm manner at the bedside. There is a PCAC. Whenever any literature you will go through related to this post-cardiac arrest neuroprognostication, they will have this PCAC. What do you mean by PCAC? This is Pittsburgh cardiac arrest category, where they have involved 3 parts: neuro exam, pressure requirement, ventilator requirement. So along with neuro, there is also like you have to think about that whether this patient having shock, how much pressure is required to keep the systolic blood pressure more than 100, and also pulmonary status, whether this patient is requiring high like FiO2 and PEEP to maintain the saturation of more than 90%. So with that background, if it is divided into category 1, category 2, category 3, and category 4. In category 1 to 3, there is actually the severe shock is associated or pulmonary dysfunction is there. Now in category 4, it is coma with loss of all the brainstem reflexes. So almost the expected survival is itself 10%. So with this, you can divide, you can categorize the patient, and also it will help you to prognosticate the family relatives that if the PCAC is category 4, so chances of survival is almost 10%. So that is a good valid point at the bedside which you can use. Now, influence of historical features on the outcome. If the etiology is VF, definitely it is better. But if it is PEA asystole, definitely it is not good. Location, yes, witnessed in hospital, better. But if it is like bystander, like has been done, like the CPR, we do not know how much time have passed before the CPR started. The duration of CPR itself, definitely this has also implications on the final outcome of the patient. Now, tools for the neurologic prognosis after cardiac arrest. No single test is 100% specific. Believe me, all the young trainees, you cannot say that I will go ahead with CT scan and the CT scan report is saying that there is a loss of gray and white matter. Definitely, I will say right now, this patient is not going to improve. No. EEG, evoke potential, there has to be a trajectory of recovery. That means you need to follow the test. It's not that single test, single day, the report is showing the lab value of this much. So you will say that this patient is not going to improve. You have to have one trajectory of recovery. Blood markers, MRI, something like that. And this has to be multiple modalities, as I have already told. And you can divide the multimodal evaluation into clinical, electrophysiologic, biomarkers, and imaging. So these are the 4, like you can say, the pillars on which your final multimodal evaluation for the neuroprognostication is actually standing. So that's why I have actually included one by one. Clinical examination, daily clinical neurology examination remains the foundation. And if you are getting, after excluding the major confounders here, such as residual sedation, so then after that also this patient is unconscious, absent or extensor motor response to pain, that is the GCS with the motor score less than equal to 2 at 72 hours or later, definitely it's a bad prognostic marker. Pupillary response, that is at 72 hours, if you are not getting bilaterally absent pupillary reflex, so it's almost less than 5% false positive rate, irrespective of whether this patient was cooled or not. It is high specific, but yes, low sensitive, because there are many cases where you will not get pupillary response. Nowadays, the qualitative pupillary response is not advised. If you are having automated infrared pupillometry, definitely it will have some more additions to your clinical examination, like quantitative measure of your pupil size, like pupillary light reflex velocity, constriction velocity. There are many other parameters which we can get rather than only the size. Automated pupillometry, the studies have been conducted in 2018 by Odo, where they have seen that persistently absent pupillary light reflex almost touches the false positive rate to be 0%. So if you are getting persistently, day 1 also automated pupillary light reflex is absent, day 2 is also absent, day 3 is also absent. That means almost you can say with certainty that this patient is having real poor outcome. Corneal reflex, that is again another like along with the pupillary reflex, but yes, specificity is slightly lower than the pupillary reflex. Why? Because it has more interference from the residual effects of the sedatives and muscle relaxants than the PLR. So along with that, we have to also check motor response, that is extensor motor response. But I would again advise all the young trainees, most recent society statements, they have actually downgraded their support for the extensor motor response, because almost in certain literatures, motor score has a very high false positive rate, almost 50%. So definitely we need to conduct this test along with more robust predictive markers like what we will discuss later on. So we need to have a trajectory of clinical examination, and we need to understand if we are getting the breathing part, the pupils, corneal reflex, oculocephalic reflex, gag and cough, they all suggest towards brainstem reflexes. So that means brainstem is real like need for the survival part. So if you are getting the brainstem reflexes persistently absent for 2 to 3 days, definitely you can think of like that this patient is going for brainstem death. Now coming to the motor response, if you are not getting any of the activities in the motor response, that will cater to the midbrain. We need to understand the midbrain part. And if you are getting localizing signs, purposeful movements, so definitely it's a good sign. Cortical activity is present, that will be actually necessary for the good outcome. So that means you can think of like continuing with your intensive care support for a long time, so that can help the patient to recover from like the stage in which the patient was shifted to an ICU. What are the limitations of clinical examination? If somebody will ask me, definitely clinical examination is having interference from the body temperature, residual effects of the sedatives and neuromuscular blocking drugs. Also, major important point here we need to understand, it cannot be concealed from the treating team. So that will have certain influence on the clinical management, and that will cause a self-fulfilling prophecy. So the treating team will be little bit of hesitant to continue with the management. So they will self-declare, or they will have slight the limitation, or maybe like little bit of hindrance in continuing with the treatment for long time. Now, coming to the another important, the prognostic marker or test, what we can use, EEG after cardiac arrest. But EEG, we need to think that it must evolve to continuous background for the patient to awaken. That means you can see here, the last left, after the cardiac arrest, it will be suppression. But slowly, there will be burst suppression. That is good, little bit better. Now it will continue here, and you can see here low amplitude waves. And after that, it will be continuous. So that is the final, like what we expect in our patient. So most changes, they occur over first 24 to 48 hours. So if you will subject your patient to EEG in the first 24 hours, you may get a suppression waveform like this. So that is not at all right now the stage in which you will prognosticate the family or something like that. So you need to wait, and you may be getting the continuous like this EEG afterwards, maybe after 2 days, 3 days. There are also certain terminology you need to understand. Highly malignant EEG. As per the American Clinical Neurophysiologic Society, this is actually suppression or burst suppression with or without discharges. That's what I have already shown you here. The first two, suppression, burst suppression. If you're continuing to get this after 2 to 3 days also, that is not a good sign. So definitely you need to exclude the sedation, metabolic situation, and also timing of EEG is very important for interpreting the result. Here also burst suppression, you can see high amplitude, identical burst, no good outcome when the background is suppressed. But yes, if background is improving later on, maybe you will get good outcome if you continue your treatment. That is a good point to understand if you are having bedside EEG. Now, EEG suppression, which is continuing for more than 36 to 48 hours, definitely the persistently discontinuous EEG, chances of recovery is definitely low. Myoclonic jerks, you need to again understand what is malignant myoclonic jerk, what is Lance-Adams variant. Malignant myoclonic jerks, they rarely recover. That is not a good sign. But Lance-Adams variant, it happens post-anoxic cardiac arrest. So mainly in those patients, it will show sometimes this patient will start moving one hand or one limb, something like that, when you will give some pain. So that is a good prognostic marker. If you're getting this type of myoclonic jerks, definitely it's a good sign and you can continue your treatment. Next, coming to the SSEP, that is the short sensory somatosensory evoked potential, short latency. And we need to understand that if you are getting absent N20 at normothermia, more than 24 hours of cardiac arrest, in absence of confounders with adequate technique, definitely it has high specificity for never awakening. Almost you can see the FPR is around 0 to 1%. So you can, with certainty, you can say that this patient is not going to improve. Just little bit about the basic physiology, the understanding about this SSEP, you can stimulate the median nerve here, and there will be connection to the somatosensory cortex here. And if there is any interruption in the pathway, like in the brachial plexus, in the high cervical area, like N9, N13, definitely it will also interfere in the final N20, which is the primary somatosensory area. So if you are getting the evoked potential here, that means it is having a good chance of recovery if you continue your management. So repeat SSEP when you are getting confounders as well as the results are discrepant with each other, because the studies have shown after day 7 also sometimes, initially day 5 you are not getting any N20 here, but after day 7 you start getting N20, P30 here. You can see here the picture. Blood levels of certain markers, yes, it's very difficult in most of the ICUs we do not have, but yes, if you are getting neurofilament light chain and you are continuing to get more than 1000 picogram per ml, it is a bad prognosis. And it has outforms the other blood markers like S100, neuron specific enolase, tau protein, something like that. So neurofilament light chain is not a very good a marker when you are getting it to be very high continuously. Now coming to the most important part, the initial CT scan. So here we need to understand what do you mean by gray-white matter ratio. Normally what happens when the edema part increases, the gray-white matter ratio is actually decreasing less than 1.1, something like that. The normal value is around 1.2 to 1.3. And our target, if it is more than 1.3, definitely it is normal. But when the edema, the cerebral edema part is increasing post cardiac arrest after 1 day, 2 days. So when you are doing the CT scan, you will get your GWR around less than 1.10. That is devastating. And when it is almost reaching less than 1, it will ultimately progress towards herniation, approaching 0% good outcome. You can see here the picture. There is loss of gray-white matter differentiation completely. But here in the first 3 pictures, you can see there is actually differentiation of the gray-white matter differentiation. Now coming to the MRI, yes, restricted diffusion, post-CPR, you can see here the picture 1 is not at all acceptable. But yes, if you are getting the other forms, the normal form here on the bottom left, this is the normal. But yes, towards the 1, 2, 3, you can see definitely there is a restricted diffusion in the DWI image. MRI brain, current prognostication guidelines, they suggest wait for a few days before subjecting your patient to the MRI. But yes, there are certain evidences, recent evidences that can show the neurologic outcome as early as 3 hours after ROSC. So finally, if you will say, discuss about the prognosis after cardiac arrest, that will depend upon the etiology of arrest. Is there any reversible condition or not? Physiologic reserve of the patient, the PCAC, the Pittsburgh, the cardiorespiratory status of the patient, and finally the neurologic prognosis with all these markers test what I have discussed in my presentation. So if we will discuss in a one slide, if we will discuss, we'll subject the patient to a CT scan. If the GWR is less than 1.1 or something like that, it will go towards the vegetative state or the brain death. Then we'll subject the patient to the EEG. If you are getting continuous waveforms, that is a good sign. But if you are getting burst suppression or absence of any activity, that is a bad sign. But yes, if you are getting NCSE, that is non-convulsive status epilepticus, definitely you can continue your treatment. Now, if you are getting cortical response with your SSEP, definitely it's a good sign. And finally, MRI, if you are doing it, if you are getting diffuse cortical damage, it is not a good sign. Maybe the patient will land up in the persistent vegetative state. So in one slide, whatever test what we have discussed about the pupillary reflex, corneal reflex, the motor response, myoclonic status epilepticus, SSEP. So you have to understand the confounding factors, also the predictive utility and the correct time frame when you should subject your patient to that test. Again, to the EEG part also, the neuron-specific knowledge and the CT scan and MRI. So a suggested prognostication algorithm, if we'll say, during the first 24 hours, I believe, and most of the neurologists, they do not prognosticate. Rather, they will wait for some time. Now, if you are getting status myoclonus or a particularly very bad CT scan in the first 24 hours itself, maybe you can take this CT scan finding or the status myoclonus to be an early opinion that yes, my patient is really bad. Now, you wait for 3 days minimum, day to 3 to 5. You have excluded all the residual sedation, metabolic confounders have been excluded. Definitely now you can subject your patient to the the further maybe EEG, maybe SSEP, and also you can check the brainstem reflexes, bilateral brainstem reflexes. If you are not getting that also, definitely you are pretty sure that yes, maybe you can confident of a poor outcome if you are getting status myoclonus within 48 hours of ROSC, high serial, all these biomarkers, unreactive EEG or status epilepticus, and also suggestive CT and MRI finding. So there are certain systematic reviews also. You can go through. This is 2020 intensive care medicine published, and they have also showed that in comatose resuscitated patients, you have to perform clinical, biochemical, neurophysiological, radiologic test along with your own experience, so that no false positive prediction within the first week after cardiac arrest survivors. So that has to be remembered. So how we did in our case, just to conclude, we have subjected the patient to the CT scan. Now the CT scan showed like this. There is definitely the GWR is more than around 1.2, 1.3 range. And we subjected the patient to the EEG. EEG showed very frequent focal electrographic seizures. Other background activity was there, but there is no generalized seizure. We started on phenytoin and valproic acid. After that, EEG normalizes. Now, by day 3, people are started reacting. Corneal reflex present, oculocephalic reflex present, patient is triggering ventilator, gag and cough reflex present, and finally patient is withdrawing extremities to the pain. On day 4, we did the MRI. MRI is showing slight early ischemic changes in the medial occipital lobes bilaterally. Now, clinical examination unchanged for almost a week after that. Critical care neurology, we are very much skeptical whether to continue with our treatment or we should prognosticate the family that this patient is not showing so much of improvement. But daughter, who is again one of the renowned writer, so she told that this is my mom. I just can't handle pulling the plug. So we did the trach and peg on day 12. And finally, patient moves to the step down unit on the trach mask. Physiotherapy, occupational therapy, they have started their work. Passive range of motion, splints. There was use of trail of arousal stimulants like ethylphenidate, amantadine, as per the neurologist advice. And finally, we could discharge the patient to the ward and after that to rehabilitation center. So to conclude, the take-home message from our talk over last 40 minutes or so, it's a multimodal approach which will be helpful at the bedside. You cannot say that this test I will do and I will get the perfect result. No test is 100% accurate. And again, I will utter this with the confidence. Not every patient will require neuron-specific knowledge or this neurofilament short chain or something like that. It's your experience, and as per the need of the hour, as per the need of the patient, definitely you have to subject the patient to that test. And again, you should have a human touch as well as be practical during the prognostication. You cannot just put your your literature at the bedside and do all the tests and all those prognostication methods. Finally, we may be able to save thousands of lives each year across the country just simply giving cardiac arrest victims. First of all, timely cardiac CPR. We have seen there was so much of debate for last 2 days that CPR should be mandatory for the schools also, for the bystanders also, everybody, so that at least people should not suffer from the cardiac arrest and they should not die because of that. And then the second point, if patient has suffered cardiac arrest, don't pull the plug too soon after cardiac arrest. Maybe we should give some time so that your prognostication, neuroprognostication is actually up to mark, so that we can save certain lives or more lives in our new day-to-day practice. Thank you all. And I think the floor is right now open for discussion. Yeah.
Yeah, thank you, Tapas. Thank you for the excellent presentation and wonderful talk, and very lucidly and well elaborated. So before going for the panel discussion, I would like to welcome Dr. Swapnil. Actually, Dr. Swapnil is also one of the panelists. He is our junior consultant, and because of some duty, he was not able to join. So let's begin the panel discussion. So as you rightly told, experience is the key here, basically. So whatever the test or whatever the literature suggests, I think a good neurophysician and a good critical care specialist can make a difference. So with this, let's hear from all other panelists, what is their experience in their center. Like Jirpe sir, I think he has one of the leading pioneer in this field. Sir, what is your experience, sir, in this about the neuroprognostication?
First, I congratulate the Tapas for excellent presentation. It was very practical, very meaningful, and it made our job easy, be frank with you. Initially, we thought we have to lead from the front, but we have to just do the commentary. Okay. So now coming back to the prognostication, even if you take your case, there is a day one, there are the clear indicators that this patient had a bad prognosis. Like there has a low pH or patient had a absent motor response. So what I see in my practice, I will not go into the theory. What I do for my practice, I see what is my role as an intensivist and the treating physician. Time 0, 24 hours, 72 hours, and 5 days. Simple. Time 0 means when I receive the patient, I come to know whether this patient is going to survive or patient is not going to survive. Shall I continue the resuscitation measure? Shall I speak with the family? And whether it is really worth in doing the all sorts of the management, like extensive bilateral extensive pneumonia with ARDS and multi-organ failure, or extreme age of the 90 plus, or metastatic cancer. I would like to speak with the family before going, because see, there is a different way. The success of the CPR and prognostication both goes in hand in hand. So when I receive the patient, the first my role starts that shall I continue or shall I speak with the family? So that is not too early. That is the time 0. I will ask the family. Second thing is the 24 hours. Yes, 24 hours gives you a lot of idea. Majority of those survival and the good prognostication you can happen. See, you come to know within 24 hours. First thing, what is the age of the patient? What is the cause of the arrest? Whether it was a cardiac arrhythmias or whether they were asystole. Third thing, whether it was intra-hospital or out of hospital. So history gives me a lot of clue. Then clinical examination. Then I would like to know what is the no flow and the low flow. What was the time required to get the return of spontaneous circulation, and how much time he or she was in hypotension. That gives me the idea, okay, I am heading towards the good prognosis or bad prognosis. And then just if suppose within 24 hours patient had a myoclonus, that gives me the click, okay, this patient might have a bad prognosis. Patient had an extension disorder. There is no response to pain. Our patient do not have any response. That also gives me, okay, but it's too early to comment. And if I do EEG and what you explain in the EEG, so EEG, your myoclonus jerks, your clear motor response, your no flow and low flow activity gives me the sufficient idea. But let me tell you, Tapas, I will not go for the CT scan unless and until I expect some bleed or some intervention. Otherwise, in that particular phase, I would like to optimize the patient more aggressively rather than shifting into the imaging. So unless and until you anticipate, you are anticipating certain, but not definitely for prognostication. And then after 72 hours, if you are not going for the TTM, that is a targeted temperature management, yes, after 72 hours, I will go with the pupillary sign, corneal reflex, again the EEG and blood levels and everything. And then if suppose you are doing TTM, then on the 5th day, so something like that, I put myself in a post-cardiac arrest situation. And then what you said is that we have to play with those clinical, biochemical, serum, radiological, those markers, and put the prognosis with experience together in front of the family. Like, okay, this patient is going to survive, but there is hardly any chance of the recovery in terms of the quality of life. So when we speak with the relative, we speak in a two language, survival and the post-survival quality of life. I think we should tell the family that what about the post-survival quality of life? And it's not the emotion of the only relatives. You need to say that your patient is going to suffer what you are going to do, like feeding tube, tracheostomy, ventilator, all. Even physiotherapies are very painful for those unconscious patients. They never able to tell us. So this is how one should look after. A theoretical part already you covered. But in practice, I would like to go ahead with this way to prognostic my post-cardiac arrest situation.
So let's hear from Dr. Harsh. Sir, what is your experience? Can you please brief for our students?
Thanks, sir. Excellent presentation, Dr. Sahu. You almost covered everything, and as Dr. Zerpe pointed out, you have covered almost practically everything. So what I would say is, say after cardiac arrest, one thing which you need to look at is the cerebral performance category of that patient. So 1 and 2 category have a different prognosis from category 3, 4, 5. And secondly, there have been studies, where you have seen death after awakening. So as Dr. Tapas rightly pointed out, giving up too early is not acceptable. You have to give the patient enough time. 72 hours is mostly what the literature would quote. And there have been studies where they have not looked at the long-term outcomes of these patients, but have just looked at awakening of these patients, although these patients don't survive long-term. But this gives us a opportunity to know that they have not succumbed out of their neurological outcomes. They have succumbed out of maybe comorbidities like your patient had pneumonia, or maybe sepsis. So all multi-organ failure, these all need to be confounded, and they cannot be clubbed with poor neurological recovery and poor neurological outcome. So that is one thing which we need to bear in mind. And as Dr. Sahu did mention, that 72 hours is probably a good time to do all these tests. So obviously it is a multimodal approach. Clinical obviously is paramount, but at the same time, it has to be confounded with your tests and your ancillary tests. EEG is something which is of importance, and EEG over time actually keeps improving, in a lot of these patients, but not always is a sign of good prognosis, even if it is improving. MRI post day 3, DWI imaging obviously carries a lot of weightage. Unless your CT shows on day 1 that there is toxic edema or there is a white cerebellar sign, then obviously having an MRI doesn't make sense. But otherwise, MRI gives you a good insight, especially after 72 hours. As Dr. Zerpe pointed out, stabilization is more important rather than imaging. I am slightly fortunate in this context that I have a portable CT scanner in the unit, so I don't have to ferry my patients. So I generally would do a CT on day 1 as well. As regards enolaces, I am not sure. They are non-specific, and majority of the places in India would not be able to do enolaces. But the crux is you have to give your patient time. Whatever, we all look at the downtimes, and we also look at recovery after circulation, all these things. But at the same time, time has to be given to the patient to recover before you can institute your prognostication tools. Other thing, hypothermia or say even normothermia, I would say would hamper your neurological prognostication. So after you've got the patient rewarmed, I would still give 24 hours before I can, post rewarming, before I can, be for sure telling them about neuroprognostication. Obviously, the human factor stays. We deal with both sides of the spectra, where people would obviously are very attached to their loved ones and they would not like to give up. But at the same time, economics runs differently as well, and a lot of patients would ask you for withdrawal as well. So if there are no brainstem signs, brainstem reflexes are absolutely signs of brain death are there, then it's a different story. But otherwise, as in Dr. Sahu's case, they did persevere because the family was insistent, and they did reach somewhere, although the patient had poor prognosis. So anoxic signs or hypoxic signs would be visible on the MRI as well. So you can prognosticate accordingly. So that is my take, a multimodal approach with a good clinical examination multiple times a day. Maybe transcranial Dopplers. SSEPs is again very important. So your sensory evoked potentials for prognostication is something which we do in our institute, can be done as well. It's a little tedious ferrying the patient, but can be done as well. Thanks.
Thank you, sir. Dr. Ujjal, what is the protocol in your neuro center?
Thank you for giving me the chance. Actually, after discussion with Kopil Zirpe sir and other sirs, it is very difficult for me to say something, but it is, I have to say something. Basically, we use a simple score, and it is, I think it is not recommended in textbook, but we use in our neuro ICU, very simple, A, B, C, D. At first when a patient is cardiac arrest and after revive from cardiac arrest, we just simply assess the ABCD, too easy to memorize. A for A is, if the patient is very elderly, the prediction. And B for either extent of brain damage, right? The most common in our ICU is traumatic brain injury, extensive hemorrhage, subarachnoid hemorrhage, etc. This patient is already a previous brain injury. And after the cardiac arrest, of course, there is secondary brain injury, right? So you can assess the prognostic. Then C for the confounder. You have to exclude the confounder, especially confounding variable like hypothermia. You all know hyponatremia and other organ failure, especially in the renal insufficiency, hepatic encephalopathy, septic shock, or sepsis. Sometimes this confounder may misguide you about patient's brain is okay, but this organ failure may misguide you about the neurologic evaluation. And then the D for the other disease, like patient is suffering from severe pneumonia, Kopil Zirpe sir mentioned, then malignancy, post-chemo, etc. So you can predict about the patient. And also D for the diagnostic imaging, right? CT or MRI. We commonly practice in our ICU a CT scan of the brain in almost all patients because it is very easy to do CT scan near to ICU. And we have the portable ventilator as well. Sometimes we move the patient if patient is stable. And we do the CT scan at least after 24 hours. And commonly we found cerebral edema, the loss of differentiation of gray and white matter, Dr. Tapush mentioned. And sometimes we also practice the MRI when the CT scan is normal. The important findings in CT scan, I want to mention pseudo-subarachnoid hemorrhage in some case. It is usually due to increase the ICP, and there is subarachnoid hemorrhage like hyperintensity shadow in cisterns. And in MRI, sometimes we do the MRI when the CT scan cannot conclude. We usually practice this. Thank you, sir.
Yeah.
So thank you very much. Yeah,
thank you.
It's a wonderful insight. Basically, I have a few more questions. When we have prognosticated and we have understood that this patient is not likely to do well, and family has decided for end-of-life support care practices, as far as withholding and withdrawal of life support care is concerned, in India, we still have, we don't have a clarity pertaining to the withholding and withdrawal. 2000, before 2008, we were actually doing withholding and withdrawal as well. But then the case went into Supreme Court, and the decision of withholding and withdrawal stagnated. So what is the current situation as far as withholding and withdrawal of the treatment is concerned? When we have prognosticated patient is not doing well and family has come up very positively and they want to withdraw, I would like to know from the panelists as to what is the current status at present. I would like to know from Dr. Sirpe sir and Dr. Sapra and Dr. Tapas also. I would like to know from you. And what is the status in Bangladesh? I would like to know from that perspective as well.
Kapil sir.
Yeah, at least there is no confusion. after the COVID, ICMR has now approved the DNR terminologies. The do not resuscitate or do not go into aggressive treatment is now well accepted terminology in India, and we are practicing after the ICMR. So legally, one should not worry about that. If the family is willing and giving it a writing, only you need to be very good in the documentation. Unfortunately, we are very poor with the documentation. Please write down everything on the paper, whatever you are discussing. Try to do the video counseling for such sessions, which gives you the medical legal security. Second thing, regarding the withdrawal and withholding, on the context of the organ donation only it is approved in current situation. Those certain centers follow, but again, I will not say on such academic platform it is allowed. Still legally withdrawal and withholding is not allowed in India, unfortunately. And regarding the euthanasia and other things, they are also not allowed. So we are fighting for that. It is a long-term battle. It takes time. Only another good thing which happened in 2018 March, I think it was the 7th of March 2018, Supreme Court accepted the advance will. If suppose in advance will someone has mentioned that he or she don't want to go on a ventilator and do an aggressive treatment and even no treatment in ICU, we have to respect that and it is legally acceptable. So in short, DNR is accepted, advance will is accepted, withdrawal and withholding is still gray area. On the context of the brain dead patient, it may be approved, and rest of the things are all of us know.
So many centers, they practice this something called as the comfort care or non-aggressive care. So it is the same thing.
No. Gurada, try and understand. We Indians have a tendency of mixing everything and then confusing the lot further. Palliative care and the end of life are two different topics. Please, palliative care starts from the home. Palliative care starts from the diagnosis, whatever this thing. And the palliative care in the ICU is a hospice. That is what we discuss in the critical ill patients when they are on this thing. But again, we are in that palliative care, don't mix the forms, the palliative care and end of life. I have seen in NABH also, we are utilizing the palliative care for the end of life, which is the wrong practice. Nobody will accept it. End of life is completely different. End of life is different terminology, different aspects as well as the legal aspect. Palliative care has a less legal aspect and more empathy, more patient targeted management is there. So don't mix that. That is the confusion we are creating. I told you now, DNR, no issue. Advance will, no issue. Withholding, withdrawal, not allowed in a regular patient in current situation. On the background of the organ brain dead donor, organ donation, yes, these are allowed. Palliative care is completely different. Don't mix that. Otherwise, the discussion will be too lengthy and too confusing.
Yes, sir. Sir, what is your take on this, sir?
So I totally agree with Dr. Zirpe on this. There's no confusion between palliation and end of life care. And also, as he rightly pointed out, withdrawal of treatment is something which is not acceptable by the legal system as yet. There are provisions of obviously advanced will, and there are also provisions of, say, a tedious but a lengthy process of, having the brainstem testing and then going to the magistrate, getting a copy. It takes 2-3 days itself, by the time probably these patients anyway succumb to what's happened around them. Mind you, all this is because because of lack of standardization in our system as well, and the misuse potential as well. So obviously that is why it is taking time to have a uniform system, because the treatment is not uniform across hospitals in India. Yes, for organ donation, I totally agree. Brainstem testing and all these things are legalized, but not for withdrawal. So that is my take on it.
Yeah. So there are 2-3 questions on the chat box. So Dr. Nishant has asked, if brain dead, then can we switch off the ventilator?
Only if organ donation. That's my take on it.
It is very controversial, because every time if you go on a debate and panel, the 50% will say that if it is a brain dead, you are declaring that. Again, it's a legal gray area. You go by your institution policy, you go by your regional policy. Don't just blindly follow one group saying just remove after the brain dead declaration, one say after the organ donation. In my hospital, we don't withdraw or withhold. They politely tell them that if you are going for the organ donation, it is officially allowed. If you are not going, our institute policy says that it is not allowed. So go by your institute policy, and if there is no policy, go back to your administrator and make the policy of your institute and take your legal advice and the legal advisor on that board to defend you. Don't get carried away by any panel discussion or debate or any article. Finally, we have to face as a person to the legal challenges, not the society.
Yes, sir. And the same thing from Dr. Nishant, if CT and MRI is mandatory, clinical diagnosis confirm the brain death, or is myoclonic is a good indicator or status myoclonus is a bad marker?
CT and MRI are must for us. See, what is organ donation? When we say clinically brain dead, that means when there is a irreversibility is confirmed. And the irreversibility is always confirmed by the CT and MRI. So, CT, MRI, that is imaging and apnea tests are mandatory in our country in current situation.
So the question is, sir, even if you do the apnea test, and is it still mandated to do the confirmatory test like EEG, CT?
No. The mandatory test for the declaration of organ donation is when clinically brain dead, certified by the expert at different time, and imaging is supporting that there is an irreversible damage. That means there is a etiology is there, like a IC bleed, or there is an infarct, or there is a multiple contusions and the devastated hypoxic injuries. Plus apnea test is positive, 2 apnea tests. In our country, there are 2. In certain countries, there are 1 apnea test. In our countries, we do the 2 apnea tests at the gap of the 6 hours. So these are confirmatory. Other all tests are, you can say, alternative, or see, for example, sometimes the treating doctor, primary doctor, or relatives do not get satisfied with all these things. Then you may go ahead with the CT angio, or you may go ahead with the EEG, or you may go ahead with the other alternative tools, but they are not the replacement for the apnea or imaging.
Yeah. So, Dr. Ujjal, the question for you from the one of the delegates: what is the appropriate care you should take in the post-resuscitation period? Like when do you what about target map, your MAP goal, and what is your fluid management, and what is your target you aim at, like lactates, your urine output, and fever temperature control, the fever management, all these things?
Thank you for this question. This is very important, post-resuscitation care. Usually we follow the therapeutic hypothermia in our context. In all private and government hospital, we use the therapeutic hypothermia. Then we use the look for the arterial blood gas and acid-base abnormality, because you know, the after cardiac arrest, there is a abnormality of the blood gas. Usually the acidosis, severe metabolic acidosis, electrolyte imbalance, and inotropic support. Some patients need the inotropic support. Fluid, you may also look for the appropriate fluid. Over fluid is also harmful for patient. It is very important to decide how much fluid is too much for this type of patient. I again repeat, how much fluid is too much. There is textbooks of Indian Society of Critical Care Medicine. There is described how much fluid is too much for the post-cardiac arrest patient. Because you know, the patient is cardiac arrest and the cardiac function is inotropic support. If you give the too much fluid, the patient will be the failure. And if you give the less fluid, the patient will remain hypotensive. So both are important. And we have to look for the urine output as well, because there is chance of acute kidney injury. You must do ECG, troponin I, and of course, the chest X-ray. After cardiac arrest, you have given the CPR and patient develop pneumothorax. You have given the inotropic support, more and more inotropy, but patient blood pressure is not improving. And chest X-ray, so there is pneumothorax, tension pneumothorax. So X-ray, you must do X-ray, blood gas, ECG, troponin I, electrolyte, and arterial blood gas, and etc. Thank you, sir.
Yes. So the one of the controversial area is the therapeutic hypothermia, basically now commonly termed as the targeted temperature management. So I would like to ask both Jirpe sir and Harsh sir, so what is your take on the therapeutic means your targeted temperature management? So still we are practicing the routine cooling the patient after the cardiac arrest, or it is the temperature which is 36 degrees we aim to keep for every patient?
See, Gunadhar, targeted temperature management is not only hypothermia. Targeted temperature management is hypothermia, normothermia, and temperature at 36. So it is not only our fever management. What we honestly, we don't follow the hypothermia of the 33 or 36% in our institute. We follow the normothermia. We treat the fever very aggressively in first 48 hours and try to avoid the complications. So that is also targeted temperature management, and we do that.
Yes, sir, what is your take, sir, on this?
Yeah, so in our center, we do practice therapeutic normothermia or mild hypothermia for these subset of patients post cardiac arrest. We generally use the surface cooling device, go up to 35 degrees, generally try to get them for 2 days of hypo or normothermia, not going below 35. And then a rewarming period of 24 hours. And that is the time when prognostication starts becoming important as well, you know, as 72 hours is what most of the literature would quote, unless they are themselves awakening up, or you can see that there are signs of, you know, neuro recovery and they are motor response is good and they're obeying commands, then we would cut short the period for you know, normothermia to 1 day rather than, you know, to 24 hours rather than 48 hours. But generally that is what we would follow. But yes, no hypothermia, but normothermia, maybe maximum we go down is to 35 degrees. That is our usual practice.
So as far as neuroprognostication protocols are concerned, it varies from institute and institute, and probably the clinicians at times may not be well versed with the neuroprognostication. So are we able to maintain a registry, or are we doing something? I mean, this question is to Dr. Zirpe, because Zirpe sir is quite actively involved in neurocritical care, and you know, this is his passion to bring uniform protocols as far as the prognostication and neuro management is concerned. So, sir, I mean, are we coming up with some data collection or streamlining the prognostication? Because the practice varies from institute to institute. Do you have anything to say about this? And what is the recent update that Indian Society of Critical Care Medicine, which is working on this, as well as protocolized treatment is concerned?
Yeah. Thanks for asking this question. And this is the right question, because Harsh is there, Tapas is there. We are running at present curing coma activity. There is a coma network has been formed, and we are coming up with the survey as well as the guidelines on management of the coma, as well as the, what you said is, see, we have Harsh and this team has established this neurocritical care in 2018 with the goal of this thing. We should have our Indian guidelines. We will come up there every year 2-3 Indian guidelines regarding the management of this thing, and one of the priority is end of life and coma and everything. So definitely it is in a pipeline, and we'll come up with that. What you said is right. Too many things spoils the that's what happening with the post cardiac arrest situation. Why we are so passionate about knowing everything about the post cardiac? Why can't we restrict it to the clinical examination, which is a possible bedside at the majority of the centers? Should be our protocol. Like clinical examination possible, imaging is possible, age is possible. Let's restrict our prognostications with that. If possible, then you can add the rest of the monitoring devices as well as the blood investigation, which may or may not be available. So what I follow is clinical examination, and the third day MRI, and if there's a myocardial EEG on the day 1, or EEG when we would like to know the brain activity, that gives you the adequate enough idea about the overall prognostication, because as such we have enough information about the patient. We just want to club it together for the better prognostication and closer to the your predictability. False positive will be there, false negative will be there. So close to your 80-85% close to your prognostication is more than enough, and not a long-term prognosis. Just go by on the 3rd day, 5th day, like you reassess and just speak with the relatives. That's what my approach in day-to-day practice. Harsh?
So I would totally concur with Dr. Zirpe. We formed the Society of Neurocritical Care in 2018. Dr. Zirpe is the present president of the society, and through the society and through ISCCM and collaboration, lot of studies are being done concurrently. Curing coma campaign is something which NCS has bestowed upon us. So this is the big thing which the two societies are working on. Tapas, myself, Dr. Zirpe are all part of the steering group of Curing Coma campaign. So as part of that, we are developing surveys which will soon be, circulated, and obviously we will need a lot of inputs from everyone to help. And obviously all the guidelines cannot come together, but we do try to get one or two guidelines in a proper fashion every year. In fact, during COVID, if you go to the guidelines, Dr. Zerpe and myself were involved in the stroke guidelines and imaging guidelines in COVID patients when COVID took over through the society. So similarly, we are in the process of creating our Indian guidelines, trying to marry the West to the East and getting something which is practical for us.
In fact, through this platform, we'd like to appeal to each every one of you. If you have certain projects or ideas regarding the neurocritical care, please do come to us, join the Neurocritical Care Society, join the hands with us. We can do the magic. That's what I always feel.
Yes, thank you.
This is really the need of the hour, sir. I mean, basically what we have seen in many centers, the clinicians have prognosticated patients, and surprisingly, some of the patients have really done well when they have been followed up over 6 months or 1 year. Probably their survival rates have improved, and the quality of life has also been seen very, very good. So I think a protocolized approach, a systematic approach, a comprehensive care for management of post-arrest is also important. And we should have a good data registry. We should have our own statistical analysis of the patients in our country, not relying on the Western literature only. I think we will be able to really have a good way of prognosticating the patients, and probably we will have a realistic approach as far as the further rehabilitation is concerned. I think the neurocritical care team is really doing wonders, and this is really required. But as for the youngsters, I think
your network is not reachable.
So just maybe one point I would like add here. We are fortunate to have Dr. Kapil Jirpe sir, Dr. Harsapra sir as actually the visionaries in neurocritical care. So the time is definitely, I will say, like the future is bright for everybody. We are planning so many things because previously there was no awareness related to neurocritical care. So these type of discussions definitely will bring more like a focus, and also the young trainees would be more interested in neurocritical care once like we can have this type of forums as well as the society like what we are right now doing. The SNCC definitely is doing a good job, at least in the Indian context, because whatever we are doing, we are following blindly the West. But yes, if we'll, as Dr. Saprasar told, if East meets West or West meets East, we are all like here to provide all our own data. So JP sir, we will definitely have our own data in certain these controversial areas from our Indian perspective. Maybe that will be useful in future, sir.
Yes, absolutely, Tapas, rightly told. So it's a time to come back to our own protocolized approach, and I think that's soon the West is going to follow us because we have the largest number of patient population probably. Tapas, the few questions for you, I think you've already answered. Like one is malignant myoclonus and how to manage it, and how to the role of ventilator and role of anti-epileptics, sedative and paralytic agents. So can you just in a nutshell briefly describe this from Dr. Nishant? To you.
So Dr. Nishant, I have already posted it in the chat box. Definitely, if you are getting malignant myoclonus in the first 24 hours, as already told by myself as well as all the panelists, it is not a very good sign. So we need to be very skeptical to face the family relatives maybe in the first 48 hours to 72 hours just to discuss about the prognosis part. yes, we need to supplement with other tests, biologic, the biochemical test as well as the radiologic test. But yes, it's not a good sign. Definitely, if you are affecting your ventilation, anesthetics and relaxants as well as anti-epileptics would be helpful. And also you are writing the timing for coronary angiography post cardiac arrest. Yes, if it is the cardiac cause and that is going to improve up your after your this coronary angiography, after stabilization in the ICU or maybe for a few hours, we'll immediately shift the patient to the cath lab for the angiography or angioplasty.
No, yeah, Dr. Tapas, I have one question. I mean, we are probably dealing with biochemical markers, assessment to the markers. We do neuron-specific knowledge. But do we have any other biomarkers like CSF lactates or assessment of CSF lactate with microdialysis, or some of the monitors like LICOX, which can tell you about real-time assessment of the perfusion of the brain? And will it be useful enough to prognosticate the patients, over a period of time? Probably, I mean, within 72 hours, it is too early to really say that the prognosis of the patient is going to be good or bad. But assessment of the CSF lactates with microdialysis and LICOX monitors can also help you. What is your thought process on this?
The literature is not very vocal about that, but yes, as per the physiology part, yes, if we can explain, yes, that will be more suggestive of that good prognosis is not there if we are getting the CSF lactate to be high. But whatever the literature says, they have revolved around this neuron specific knowledge as well as short fiber length protein, and then tau protein S100B. So we can have one big study, something like that, to have at least feasible. CSF lactate is very feasible in our ICUs. We can do that, as well as microdialysis. I have no experience as such in the prognostication part, but yes, it is invasive, and in those crucial times, doing one more invasive procedure, as well as after that the complications, we need to again explain to the family, take the consent when the patient has already suffered this type of event. So definitely the test need little bit of more supervision from the neurosurgery as well as the neurointensivist. Definitely. Harsha sir, any thoughts on this?
Yes, so I would like to point out CSF lactates are more so for bacterial meningitis rather than prognostication and neurological recovery. So that is more so.
Sir, you are muted.
Yeah, just a minute, sir. So they are CSF lactate is more for neuroprognostication for meningitis rather than for neuroprognostication itself. Microdialysis is a good tool, but at the same time, as Dr. Sahu pointed out, is an invasive tool, is not available in India either. So that is again, is again out something which is not practiced in our country. Enolases, tau proteins, all these biomarkers again are not available in India as yet, and are anyway non-specific. So I think they would probably not add to other investigations which we can do, like EEGs. Transcranial Doppler is something which I would recommend if you are looking for neuroprognostication, especially as an ancillary test to brainstem death, or even neuroprognostication. Your flow velocities and things would give you a lot of information. Continuous transcranial Dopplers is something which you can do. And if you really want a test to declare brain death, although as Dr. Zerpe pointed out, clinical tests are paramount, and that alone are enough to say that the patient's brain dead. But again, if the patient still insists, digital subtraction angiography showing no forward flow is something which can be done, but not CSF lactates, and the other two are not feasible in the Indian context. So that is my take on that.
Yes. So
I want to add something, sir.
Yeah, please.
Regarding the CSF lactate, it is we do not recommend and we do not support the CSF lactate because in this stage the patient is already in cerebral edema, where you do the LP and there is chance of corning herniation. So it is theoretically applied, but practically it is too difficult and may be harmful for the patient. So we inhibit the CSF lactate. CSF lactate we usually do when the patient is already done in the ventricular drainage to find out the bacterial hospital-acquired bacterial meningitis. There is role of CSF lactate here. Otherwise, to diagnose our prognosis, to assess the prognosis, we usually do not practice the CSF lactate. Harish Sprasar correctly mentioned, we usually practice in our ICU the bedside TCT, and also the sonography to assess the diameter of the optic nerve sheet, to assess the raised ICP, and you can also assess the proper blood flow by TCD. It is usually the non-invasive and very easy to practice in ICU settings, in the bedside. Thank you.
Another, let
Yes,
me
sir.
add we are missing the metabolic factors which we need to discuss in a post-cardiac arrest situation. Like we are talking about the CSF lactate. Lactate clearance has a value in a prognostication. So generally, the lactate, serum lactate shows the downward trending in first 6 hours. Then it may be the predictor of the good mortality. And there is you need to do a proper, it was in a critical care medicine 2017, there was a SOS Canto study which was released. The serum lactate clearance has a prognostication, good prognostication in the post-cardiac arrest situation. You do the 0 hour lactate, you do it after 6 hours. So 0 hour minus 6 hours divided by the 0 hour into 100 and you calculate the positive value predicts the good prognosis and the negative value predicts the poor lactate clearance. So, but we need to understand there are a lot of confounders which can lead to the high lactate levels like infection, sedation, hypothermia. There are so many other things are there, hypoperfusion. Second thing, hyperkalemia has a bad prognostic outcome, this thing. Third thing is hyperglycemia and hypoglycemia and glycemic variability. This was done from that trial, which was, I think, from the Lancet trial. It was therapeutic targeted trial. That was from that we have subgroup analysis. Ad hoc analysis shows that hypoglycemia, hyperglycemia, and glycemic variability has a poor prognostication if anything has happened during the. So these things give you the idea. They are not the one way to predict, but these are the additional things may guide you along with the myoclonus, along with the poor clinical outcome, along with the bad radiological imaging.
So thank you, sir. So before we conclude, just a last question from my side. Basically, if sometimes we see signs of recovery in a comatose patient in the form of investigation, MRI, imaging, or clinical parameters. So particularly how much time some person has to, or so the intensivist has to wait, or the physician has to wait. And when the family is anxious and they continuously ask how much time it will take for the patient to recover, and what about the consequences of this, means the outcome, neurological outcome. So how do we guide them, sir? Because sometimes after a year, we find that the patient sometimes improve a lot. And so what is the exact recommendations from different societies?
Tapas, you have presented that various formulas and the statistics analysis.
Very difficult, Dr. Gunadhar. The false pessimistic ideas, then the false positive rates, then the Bayesian principle, what we have all discussed. It's all the clinician's experience as well as the test for the observation what we do for at least 7 days or 10 days, because it's like what we have discussed: 0, 3 days, 5 days, 7 days, something like that. Because we cannot continue enough for in Indian context. We need to think about our resources also, and we need to be practical also. Yes, the literature shows that if you continue that the post test, I have given that picture. There will be 5%, 3% out of 100 the persons, the patients, they will survive. But should we continue to do all these things for 100% so that we will get only 2 to 3 patients alive after 1 year? So it's a big, difficult question, emotional question. We cannot justify, but yes, the 1 or 2 patients who will be dying, they may definitely ask us that you have not given enough chance for continuing the care.
So, on the lighter note, when I started neurocritical care in 2002, dedicated neurocritical care in Rubio Hall, one of the senior neurosurgeon came to me. He said, "Congratulations, Dr. Jetpe. You will save the many more life, but now you are going to create the many more vegetative body." So I said, whether it is a compliment or it is a way, I don't know. Still, I am trying to understand what was meant by him, whether his experience or reality.
Absolutely, absolutely. So, sir, sir, I just like to thank you. And any take-home message, or you want to give some message to our trainee and the newly joined person, and what is, sir, your message to them, sir, in this forum?
Message is very clear. When we are coming across the post-cardiac arrest situation, don't rush for anything. Rather, the good prognosis as well as the bad prognosis. Do your job. Go time slot accordingly. You predict the mortality. Have a good communication with the families. Out of all these things, what connection you able to do with the family, eye contact as well as their trust, is going to take you the easier way to manage that patient, because sometimes it may be the 2 months or 3 months affair. And if initially few days, if you do not have a rapport with the patients and the relatives, your life will be miserable, irrespective of the results, whether bad or good prognosis. So I will say, don't be emotional, be practical, be patient, and don't give up at any point. Try to assess, reassess, assess, and have a good communication with the family. That's the key of success, irrespective of the results. Again, I'm saying we are not God. We will not predict anything. We will just give some you can say the thought process in front of the relative. This is a possibility, and we'll go ahead with that. But patience, patience, and patience.
Thank you, sir. Thank you. What is your message to all the trainees, Tapas? I think you have also started some this critical care courses for all the new joining and DNB and EDIC preparatory courses. Yeah. So just one message to them.
So apart from like the neuroprognostication, so many things have been discussed in this forum today. So I would request everybody or advise like to do the basics in the critical care in a better way, because sir has already told. Already the patient has suffered a lot from cardiac cause, but from the neuro cause, something like that. But if you are continuing with good supportive care at the bedside, at least we are not harming the patient more, or we are not allowing the patient to deteriorate further. And time will heal. Maybe if the patient is destined, something is there apart from your own hard work, definitely something will happen to the patient, and they maybe 10%, 20% patients will recover. And that is our the pride of treating the patients in so much of algorithm approach or whatever we have discussed today. And from my side, we have started one critical care academy for training in India for all these DNB super specialty, as well as for the European diploma, the part 1, part 2 also. So there has to be strong academics. As Dr. Gunadhar and Dr. Akhilesh have started this initiative, we need to conduct this type of forums, discussions, and courses, training modules, so that at least compared to the Western countries, we should have also very quality academics in our own country and in our own training period. And for that reason, anytime any help is required, I would be more than happy to help in this forum.
Yeah, thank you, Tapas. Sir, what is your take-home message to all our DNB students and the fellows, sir?
My take-home message would be that there is nothing more paramount to good fundamentals of critical care, leave alone neurocritical care. The ABCs of critical care remain the same everywhere. Neuroprognostication comes number 2 after basics of critical care. So if your basics are right, you'll be able to prognosticate rightly. And you would know, by 96 hours, majority of things would be clear whether the prognostication is going uphill or it is going downhill, So I would suggest, as Dr. Sahu also suggested, the basics of critical care are paramount.
Thank you, sir. And Dr. Ujjal?
Thank you, sir. I'm totally agree with Dr. Taposh, Dr. Haris sir, and Kapil Zilpe sir. But I have to take a message. Always for junior, always trust on clinical examination, and you must do clinical examination at least 6 and 12 hours apart. Never depend upon on single examination. And you have to exclude the confounder, especially sedative. we usually use the sedative, long-acting sedative. The patient who has gone the cardiac arrest, previously he has done the sedation, long-acting sedation like phenterline, midazolam, etc. So, this type of sedation may alter the consciousness, and you may not assess the consciousness of the patient. So you have to examine the patient in several times, 6 or 12 hours apart. You have to assess the patient clinically rather than radiologically or biochemically. You of course have to do the investigation, but always depend upon the clinical examination. And the second thing is that you have to ask to examine your senior or your other colleague to confirm that you are in the right track. And always keep in touch with the family members. As Kapil Zirpesar said, you counsel this type of patient several times. Sometimes you may visit the patient with family member with empathy and sympathy. Thank you. Thank you very much.
Yeah, thank you. So with this, we'll conclude the session. I really thanks Dr. Tapas for the excellent and very elaborative presentation, Harsh sir for excellent discussion, and Jitpe sir for enlightening us the newer and the recent methodology of treating such patient. Dr. Ujjal for his ideology and the message. Dr. Akhilesh for the excellent moderation, and Dr. Swapnil, of course, is not available today for the duties. So we can conclude, and next week also we have sessions on lung ultrasound. So I request all of you to be remain there and invite all the panelists and speakers also. So thank you from our side, from the Apollo Navi Mumbai group.
Thank you all.
everyone.
Thanks for having us. Thank you.
Good night.
Thank you,
Thank you.
sir.
Thank you very much.
Thank you.
Thank you, sir.